You've been in the workshop for the last, I mean, you've been finishing the today workshops. We all know there's a strategy by which we approach media. Okay? Is the strategy clear? Can somebody tell me what is the strategy with which we approach media? Yeah, tonality will not be the right word in English. More direct to identify the plan. But anything else basic, what are we looking for? How is the initial diagnosis for leukoplakia? Blood, right? So we need blood, whether in peripheral blood or in marrow or whatever, we need that 20% cutoff. But that 20% cutoff, if you see the recent WHO 21 update, that 20% cutoff has also been waived off for a large number of leukemias. So we are now going to the molecular era. But apart from that, yes, today also we try to look for blast, right? And in flow, how do you look for blast? Yeah, so you establish a template, a blast window, right? You know that this is the template, this is the window, this is where your abnormal population will come. Is that clear to all of you? This has been taught to you for these last 2 days, right? So how do you identify blast? These are cells which are immature, they have a low site scatter, they are CD45 positive, generally variable. Yeah, it can be dim. It depends on what lineage blast. Like T blast would be CD45 bright, right? B blast would be CD45 dim. Myeloid blast would be somewhere in between, correct? And apart from that, we know that they have to establish, they have to show some immaturity markers. The most important immaturity marker is CD34. We also use TDT, we also use HLR, but the HLA-DR, but the most important is CD34. So blast is a population which is CD45 positive, CD34 positive, and it has a low site scatter. This is how we identify the blast. And then the next step is to go on and do a lineage identification. So we know if you've gone through the EGIL classification or the WHO 2021 update, you know that they have established that for B lineage, you need CD19 strong or dim along with CD10, CD22 and all. Similarly, for T lineage, you need CD3, and for myeloid and monocytic lineage, you need whatever things, right? So this is how we go about all our cases. Now, not every case is going to fall into this category. And I will just be trying to discuss a few of these cases when this simple and straightforward approach might not give us the right answer, right? So this is my first case. This is a very recent case. We've just made this diagnosis, and it was a mind-boggling case. This was a 3-year-old child. And you can imagine कि 3 साल का बच्चा बीमार है, तो the father must be so high. मतलब he was really worried, and he had been having fever for the last 6 months. So 6 months से he had fever, and there was some history of episodes of abnormal flexion. Lasting for 5 to 10 minutes, and then the child would become drowsy and he would be fine after an hour or so, and this would happen every 3 or 4 days. That was the only positive history we had. There was nothing else in the history. He had 2 siblings, they were fine. Nothing in the past history, family history, everything fine. On examination, we saw there was no facial dysmorphism, no other anomaly, no syndromic, nothing looked like a syndrome kind of a thing, and he was having pallor, severe pallor, but no icterus. And obviously, as a hematologist, the next thing you do is you look for the lymph nodes and the liver and spleen. So hepatosplenomegaly was not there, no lymphadenopathy. So that was his basic profile. Since he had been ill for the past 6 months, so the parents were running from pillar to post, and already we had a list of battery of investigations which had already been done, which included his CBC. He had microcytic hypochromic RBCs, but his iron profile had been done twice, and both times serum iron and TIBC and TSAT, everything was within normal limits. B12 and folate had also been done. He had underwent a hemolytic workup. His HPLC I myself saw was fine. G6PD, PNH screening, there was no clone in PNH by flow cytometry. Since he was having this abnormal flexion, he had got a brain scans done. They were also normal. His fever panel had been done multiple times, always came out to be negative, and viral markers were negative. So we could not find what was the cause of fever. And then when you have a condition where there's a pyrexia of unknown origin, then what is the next thing to do? The next thing to do is a bone marrow. So the bone marrow and aspirate and hemogram was received, and the hemogram did show some microcytic hypochromic cells. His WBC was borderline, but platelets and hemoglobin were definitely low. And so we saw some reactive lymphoid cells and nothing else in the hemogram. So microcytic hypochromic cells and some reactive lymphoid cells, nothing else. This was the bone marrow aspirate. You can see in the bone marrow aspirate, the arrows here are showing you, what is this? This is what is this? Can somebody tell me what is this? This is a myeloid precursor, right? We're talking about a bone marrow. So this is definitely a myeloid precursor. And what is it showing? It is showing, is it normal? Can you classify it into one of the stages, a myeloblast or a promyelo or a myelo or something like that? So this is definitely dysmyelopoiesis. Okay, this is dysmyelopoiesis. And another one, this, if you identify the cytoplasm, this is the erythroid cell. This is showing you dyserythropoiesis. Another arrow there, again, dyserythropoiesis. So that is all we saw. We could not tell what was the cellularity because the marrow was completely diluted, aparticulate. What we saw was some myeloid and erythroid precursors with dyserythropoiesis and dysmyelopoiesis. So let's move on. What happens next? What was the provisional diagnosis? A 3-year-old child with dyspoiesis. So we thought, were we dealing with a congenital dyserythropoietic anemia? Was it a childhood MDS or was it sideroblastic anemia? So what we could do in the lab was we did a HEMPAS. HEMPAS kiske liye karte hain? We do it for CDA, right? So HEMPAS came out to be negative. So HEMPAS was negative, though all CDA will not show you a positive HEMPAS. But yeah, for so far, we could say that CDA nahi lag raha hai. But what about the other two things? We couldn't do an ion on the bone marrow aspirate because there was no particle. So we couldn't do an ion, childhood MDS. We want what to do next. Then we told the clinician कि नहीं इसका aspirate आप repeat करो, diluted आया है, do an aspirate and also do a biopsy. Abhi tak bhi we have to tell the clinicians again and again ki please do a biopsy along with the aspirate. This is a normal practice that they would get away with an aspirate and not do a biopsy, right? So we told them to repeat the procedure and this is the repeat biopsy. Now, because the child had been running here and there, the parent had to be convinced again. And 15-20 days later, the repeat bone marrow aspirate and biopsy was received in the department. And see, look at the cell. This was there in the peripheral smear. More of these cells. They were very clear. Approximately 15 to 20% of these cells. Okay. So looking at them, what do you think? Are they normal cells? Are they reactive lymphoid cells? Now the ears were ringing and we really thought, are we dealing with a blast population, right? Though it was not 20%, but yes, they were looking very atypical. They had a high NC ratio and they had basophilic cytoplasm and some of them did have good nucleoli. So we were thinking of whether are we dealing with a leukemia, and along with blast, again, even in peripheral smear, we could see dysmyelopoiesis. So there was dysmyelopoiesis and there were blasts. So this was, again, the aspirate was again diluted. We could not get anything in the aspirate, but we luckily had an imprint, and this is the low part of the imprint. Okay, so peripheral smear showing us some blast, and the imprint is, this particle is definitely hypocellular for a 3-year-old child, right? So the imprint had only one particle, it was hypocellular, but luckily there was some background population, enough background population, which we wanted to see on a higher power. So let's see what we see here. This is the high power of the imprint. Now similar cells, full. Here you see so many similar cells. And here the blast morphology is even more clear, right? Peripheral smear may still plus minus doubt tha. But when you look at the imprint, you are damn sure that yes, these are blast. They have a high NC ratio, prominent nucleoli, and basophilic. Look at the deep basophilic cytoplasm. Okay. And again, the arrows are showing you the dyserythropoiesis. So again, you have ring form, dysmyelopoiesis. This is again pelguroid abnormality. So this is dysmyelopoiesis and there is dyserythropoiesis. So again, dyserythropoiesis, dysmyelopoiesis and blasts, right? So definitely the diagnosis was now changed. CDA was out, sideroblastic anemia was out. What was in? Are we dealing with the childhood MDS with increased blast, right? So the blast have already crossed approximately 20%. So ab hoga bhi to we will call it as hypocellular acute leukemia. But acute leukemia problem was that the child had a history of 6 months. That's abnormal. Acute leukemia usually have a stormy onset. They don't show you a history of 6 months. So ye problem tha ki history was long. There was no hepatosplenomegaly. We checked the child again. There was no hepatosplenomegaly, and obviously hypocellular ALL or AML is an uncommon entity. So the next step was to do a flow cytometry. This was done on peripheral blood. This is the flow cytometry. Now, can you see there are, you know what this population, the blue population is? That's the grans. Yeah, this is monocytes, this is lymphocytes. And yeah, this is the atypical population here. Okay, so we do have an atypical population here, and we did have a population here also. So we gated both these populations. This population was followed up, but actually this turned out to be debris. And how did we know that this was debris? It was negative for all markers, not just CD45. See, remember, CD45 may be negative in certain populations, all right? So when how to classify this as debris, it was not expressing any of the markers in any of the tubes, right? So we understood that, yes, this is the population which we don't have to bother about. This is probably debris. But this is the population which needs to be evaluated. So we've gated this population in red color and see what is it expressing. It's expressing here CD2, right? This is CD2 positive and CD7 positive, right? This is a nice bright expression of CD2 and a variable expression of CD7, right? So this was positive for CD2 and CD7, but CD19 is negative. Okay, this is the CD19 here on y-axis. So CD19 is negative. And it also expressed, it was not expressing CD3. So CD3, the T lineage is out, right? So CD3 not expressed. Look at CD34 and HLA-DR. These are the immaturity markers, not expressed, okay? So it's not expressing any of the immaturity markers. CD13 and 33, which lineage? The myeloid lineage, okay? So two markers of myeloid lineage are here. So myeloid lineage markers, two of them expressed, and 34 and HLA-DR also negative. Let's go on further. Does not express CD8. CD8 is also negative. CD11B, CD64, all these are negative. This was the next tube. CD4 is also negative here. This is CD4. This is the positive CD4 population. So CD4 versus CD3 graph, this gives you, this is the T helper cells. This is the cytotoxic T cell, and these are the B cells, right? So this one is the blast population, which is not expressing any of the T lineage markers also, only expression of CD38 here. CD38, which is variable and heterogeneous, right? So this is, and this is the cytoplasmic tube. Okay, so we do put a cytoplasmic tube also for my lineage identification. And the cytoplasmic tube also told us that all lineage, myeloid, T and B, they were negative for all three of them. Okay, so what is the result on flow cytometry? There's a 55% gated population showing you dim CD45 and a moderate site scatter. Did you look at the site scatter here? The site scatter is not normally what your blast would give you. The blasts lie here. They have a lower site scatter. But here the site scatter is somewhere up. It's coming as far as the grans. Okay, so this is a population showing you dim CD45 and a moderate site scatter. It is negative for almost all your markers except some myeloid markers, 2 and 7, and some heterogeneous expression of CD38. So any takers now? What is the diagnosis? Looking at the flow cytometry. If I show you this graph and the flow cytometry graphs, and you don't know the history, what diagnosis are you going to make? I want to ask you. ETP-ALL, good. ETP-ALL can be one possibility, but the cytoplasmic CD3 is negative. ETP-ALLs are cytoplasmic CD3, usually positive, right? Usually no, but they have to be positive for CD3. Anything else? Acute undifferentiated leukemia. Anything else with this kind of a site scatter which is high? Which leukemia shows you such kind of a high site scatter? Any cell site scatter क्यों होता है? Because of granny. कौन सा leukemia होता है जिसमें granny? APML, right? So APML is one leukemia which shows you a high site scatter. It is positive for myeloid 13 and 33, usually negative for 34 and HLA-DR. Okay, HLA-DR is variable, but 34 is usually negative. तो अगर किसी को आप ये flow दिखाओगे, तो first of all he will think of is an APML. Acute leukemia was clear to us. Ab kaun sa acute leukemia is the story. So differential goes acute promyelocytic leukemia. As we said, what is against APML here? How do you explain the history of 6 months in APML? Right? And the MPO cytochemistry as well as MPO on flow cytometry is negative. So APML is a difficult diagnosis to make. The second possibility we kept was a plasma cell leukemia. But plasma cells का यहाँ problem क्या है? Plasma cell leukemia does not happen at this stage. One thing. Second, plasma cells will not show you such a high site scatter. We don't have granules. Okay? So normally the site scatter is not so high. Then the third was, yes, an undifferentiated leukemia or an M0 AML. And the fourth was an ETP-ALL with a dim cytoplasmic CD3 expression. और कभी-कभी ऐसा होता है AML में. Then you need to change your clone of CD3. Okay, and see whether it is coming positive with another clone of CD3. So we were still, scratching our heads ki hoga kya ab iska. We were lucky we had a biopsy now. This was the bone marrow biopsy. Look at the bone marrow biopsy. What is it showing? Hypocellular biopsy. And anything else which you can see on low power, which is here quite visible? Streaming. Yes. So it's showing you streaming and fibrosis. Okay. So a hypocellular biopsy showing you streaming and fibrosis. Okay. This is again, you see the areas which were showing high power view. There are these fibroblastic stromal proliferation and here and there lying atypical cells. Okay. And along with these areas, these hypocellular areas, we also had some areas which were showing you these atypical monomorphic population clustered. Another high power view, these monomorphic atypical cells which had vesicular nuclei. So a 3-year-old child, no hepatosplenomegaly, marrow showing fibrosis, definitely blasts are there. Any takers now? This was what clinched the diagnosis for us ki abhi aage kya karna hai. Any takers? Mast cells. Mast cells will show you this kind of a flow cytometric, this thing. Fibrosis कौन से leukemia में होती है? Somebody said M7? Very good. So it was, what we did next was we put an IHC on the bone marrow biopsy looking at the fibrosis. This is CD34, which was positive in a few of cells. This is TDT, negative. CD61 is a megakaryocytic lineage marker. CD61 is a very, I would say, an infidelity marker. Kabhi positive aayega, kabhi nahi aayega. But yes, CD41 was positive. Okay. So yes, CD41 was positive and another flow tube was put. We saw the blasts were expressing CD41. So the diagnosis was acute megakaryoblast leukemia, right? Now, acute megakaryoblast leukemia is a very rare diagnosis. It is seen more commonly in children. The reason is that it occurs in association with Down syndrome, right? And it has certain unique features. When I read about it, hepatosplenomegaly is actually infrequent in acute megakaryocytic leukemias. They can show thrombocytopenia, thrombocytosis. There is definite dysplasia in all lineages. And marrow has fibrosis. That is because of the megakaryocytes, right? And we establish the megakaryocytic lineage based on 4161, or you have to do an electron microscopy. So, as I told you, acute megakaryocytic leukemia, they can be seen either in children with Down syndrome or in a non-Downs phenotype. So the Downs one is which we have commonly seen, where it is associated with TMD, that is transient myelopoietic disease, and it shows you a GATA1 mutation, right? Now, these ones have a good prognosis. There is a good response to chemotherapy. But there is another entity, the non-Downs AMKL, okay? This one is extremely rare. There are other chimeric oncogenes which are associated with this one, and the prognosis is poor. So we went on to do a karyotype of the child because we wanted to see whether he is having though we did not see any facial anomaly or something, we still did a karyotype, and the child had a normal diploid male karyotype. So trisomy 21 was ruled out. There was no translocation in the karyotype. We went on to do molecular studies. Why did we do an ABL BCR here? There was another differential. That was pediatric CML with a megakaryoblast crisis. And I have seen 2 such cases of pediatric CML developing into megakaryoblast crisis. So we had to rule out an ABL BCR transcript. But what we got was an RBM. That's the RNA binding motif 15 MKL1 chimera, which was just revealed on the molecular study. And so the final diagnosis which was rendered was a non-Downs AMKL with this kind of a gene fusion, WHO category AML with defining genetic abnormalities. Okay. So APMKL with RBM15 MKML chimeric oncogene results from a translocation between chromosome 1 and 22. The short arm of chromosome 1 and the long arm of chromosome 22, also known as the OTT maltranscript. Okay. And this is associated with specifically younger age, lower percentage of blast and dysmegakaryocytopoiesis. We did not somehow see any megakaryocytes in the marrow. There was hardly any megakaryocytes which we saw. And this one has relatively better prognosis as compared to the whole non-Downs group, right? And rarely the karyotype may be normal. Thus, molecular studies are advocated in all these situations, right? So this was a very rare case of non-Downs AMKL with a normal karyotype. So that is the importance of the molecular studies, which again and again is being stressed in all the classifications, that yes, you cannot do away with molecular studies. If you are in a center where you don't have scope of molecular studies, you at least collaborate or make some contacts with people who can help you doing the molecular studies, right? So this was this case. Next, coming to second case, this is a 4-year-old male child. He had complaints of cough and fever, serial hemogram, pancytopenia. Again, nothing found in blood, no chances of infection. He just had a spleen 4 centimeter in size. And the clinical diagnosis was again pyrexia of unknown origin, or they were also thinking of aplastic, and they sent us a marrow. Now, this is the marrow, the peripheral smear. The platelet count was fine. In the peripheral smear, we saw some macrocytes, nothing much. So the first impression was bicytopenia, no atypical cells. This is the marrow, again diluted marrow, some myeloid precursors and erythroid precursors here and there. So we went on to see the biopsy. Now this is the biopsy of this child. What do you see in the biopsy? Again, cellular marrow, yeah, and megakaryocyte clusters, cloud-like megakaryocytes, and again the streaming. Okay, so what is the diagnosis here? The morphological diagnosis when you see streaming cellular marrow, myelofibrosis, right? So the first diagnosis was, and we confirmed that on a reticulin stain, you can see that there is grade 2 myelofibrosis. So the diagnosis which was given was myelofibrosis grade 2. So this was a child who had myelofibrosis, right? Now what happens next? We told them to rule out secondary causes in this child, and we had to do a JAK2 mutation at least. So this is a child with fever, bicytopenia, and splenomegaly, now having myelofibrosis in the bone marrow, right? So far, so good. What happens? Further investigations are being done. It turns out that the serum ferritin is very high. Also, the TAGs are raised. So what panel does it fit into? What criteria does it fit into? HLH, yeah? So it fits into the HLH criteria. So the diagnosis was revised, hemophagocytic lymphohistiocytosis with myelofibrosis. All right. The child was cited on the HLH 2004 protocol. He became better. His JAK2 came out to be negative. No secondary causes of myelofibrosis could be found, and everything went well for the next 8 weeks. Now the child went home. What happens? He comes back after 6 months. What happens after 6 months? He again develops bicytopenia and persistent fever. So the clinicians think that it is a relapse of HLH. So they again do their own all investigations, but they also do a bone marrow. And this is what you now get in the bone marrow. Some atypical cells. Okay. Again, there are few atypical cells. Hemoglobin is still fine, but TLC is very low. Platelets are low. Few atypical cells, MPO and PS, negative. Aspirate is particulate, it is cellular. Look at the high power in the aspirate, very clear blasts. And what kind of blasts? What are these blasts? Lymphoblasts. You see the hand mirror morphology in some of them, right? So there are lymphoblasts, enough lymphoblasts to look at and say that it is ALL, right? So this was the bone marrow biopsy. Pehle bhi fibrosis tha. The fibrosis was evident right here also. In the biopsy, there were again areas which showed you this monomorphic population of cells apart from the fibrotic areas. So there were these monomorphic population of cells with vesicular nuclei, prominent nucleoli. We went on to do a flow cytometry. Here, Abhi, Dr. Sadiq was showing you something. What are these? This is the blast, right? If I just show you this graph, what would you think of? Probably B blast. Yeah. So a negative to a dim CD45 and a low size scatter. So the B blasts were confirmed. They were 34 positive, 19 positive. No issues here. Expressing 38. 20 was negative. That is expressed by more mature B cells. The 10 was positive. So fine. We were dealing with this is again your T tube. So we had the biopsy also. So we put the IHC also. And finally, yes, it was a Kala positive B cell ALL. So the story is good till now. But my problem is, so the final diagnosis was an acute leukemia, lymphoblastic leukemia, following HLH and myelofibrosis. Now, the problem here is, what is the genesis of BALL in this case? Did it arise because of myelofibrosis? Did it arise out of HLH? Did it arise out of drugs which we gave in the HLH protocol? Or was it a case of simply de novo BALL? So if I talk of progression of myelofibrosis, you know that myelofibrosis is usually a disease of old age, and whatever leukemias are known to arise from myelofibrosis are the AMLs and not ALLs, right? There is a paper by Delario et al. Which shows that primary idiopathic pediatric myelofibrosis is a distinct disease entity. It is very different from adult myelofibrosis. It has less amount of fibrosis. The JAK2 mutation and the MPL mutation was negative. What are the three mutations which are commonly associated? The JAK2, MPL, and the CARA. There can be other common mutations also. So all these cases were negative for JAK2 and MPL, and there were no chromosomal anomalies. Evolution to leukemia is uncommon. But there is another paper from a Chinese group, Won et al. They said they studied approximately 14 pediatric patients with myelofibrosis, and they found that 43% of them developed AML. All of them developed AML. None of them developed ALL, right? And CALR mutations were seen in 50% of these children. So we searched on more, and we found this article from JAMA 1979. There was a case reported where idiopathic myelofibrosis was followed by acute lymphoblastic leukemia. Okay. Then there was another paper in 2018 where they did some review of literature also, and they found that there were 6 or 7 cases where myelofibrosis had developed, children with myelofibrosis had developed ALL, both B and TALL. But yes, this was a far-fetched diagnosis. This is quite a rare phenomena to occur. The second possibility was HLH, right? So HLH in children is more mainly due to either it is familial or it is association with Epstein-Barr virus or immunodeficiency, right? Some malignancies are associated with HLH, but those are usually lymphomas, NK and T cell lymphomas. And it is always seen that malignancy occurs and then HLH happens. It never happens that first it is HLH and then malignancy. So this was also a difficult diagnosis to make. The third possibility was drugs, right? So what drugs do we give in HLH protocol? We usually use these drugs, DEXA, BP16 is a topocyte, topoisomerase inhibitor, cyclosporin, and intrathecal methotrexate, right? These are the 4 drugs which are given for at least a period of 8 weeks, depending on how and what the condition is. Then etoposide is a topoisomerase inhibitor, which is associated with secondary malignancies. Okay, but all of them again are AML. And the mechanism is the MLL gene rearrangement. Okay, so all leukemias which have been known to be associated with etoposide are mostly AMLs or MDS. Yes, we found a series of Shiv Kumar et al. Where 101 cases of secondary ALLs were seen, and 30% of these patients had received topoisomerase inhibitor. And the median interval time was 1 year. Then this is a very interesting paper which I recently went through. This is by Sagan et al. They have actually studied these patients. The CALL is a therapy-related ALL. Okay, so they had a cohort of 116 patients of therapy-related ALL. They took 100 subjects with de novo ALL, and these 20 patients, they had post-malignancy ALL. And when they compared these 3 cohorts, they went on to say that the overall survival as well as the relapse-free survival was very poor in these therapy-related ALL subjects. Okay, and they found that they had a higher frequency of poor risk cytogenetic factors. So these authors, they said that collectively their results support that TALL, a therapy-related ALL, is a distinct entity. And it shows you mutations which are normally seen in the myeloid neoplasms. So we all know that in the WHO classification, we have a separate category for therapy-related myeloid neoplasms. And it's time maybe in the next few years or so, we will have another category of therapy-related ALLs as well. Okay, so that is why I kept this case. The patient was put on a BFM 95 protocol, and post-marrow in the post-induction marrow was negative for MRD, and the patient is doing well. So this was just a case to speculate that yes, there can be sometimes atypical presentation and the way these leukemias can develop. So this is the third case. This is a 46-year-old lady who developed shortness of breath and facial puffiness. No other positive history. She had pallor, no hepatosplenomegaly, no lymphadenopathy. Her blood pressure was fine. The abdominal ultrasound was fine. Her RFT was arranged. Creatinine urea was high. Okay. So a 46-year-old lady with high creatinine urea, facial puffiness. A bone marrow aspiration and biopsy was received. And look at these cells. Again, a lot of atypical cells here. Okay. And these cells show you a high NC ratio, again, indistinct nuclei and cytoplasm showing you some cytoplasmic projections. Okay. So what is the first diagnosis? Looking at this. Are these blasts? Are you sure they are blasts? They can be blasts. Even I thought of blasts. They definitely can be blasts. They are atypical cells with very high NC ratio. If I'm not able to see any nuclei, that doesn't mean that they are not blasts. Okay. So one possibility is definitely an acute leukemia. What is the second possibility? Looking at cytoplasmic projection in conjugated nuclei. Yeah, so you can think of a lymphoproliferative disorder, a hairy cell or a hairy cell variant. So that is the two things I thought of. And a bone marrow aspirate was the next thing which was received. So this is the bone marrow aspirate. You see that these atypical cells are almost replacing the normal hematopoietic precursors. They have a high NC ratio here, and many of them are they visible? Many of them are showing you multiple prominent nucleoli. So nucleoli peripheral smear में उतने clear नहीं थे, but in the marrow the nucleoli were very clear. So I was more in favor of blast as compared to a hairy cell. Do hairy cells show prominent nucleoli? They don't, right? So hairy cells, I was not thinking of much, but yes, a hairy cell variant can be a possibility. So the first diagnosis which I made was a leukemia, acute leukemia, oblique a lymphoproliferative disorder. And the next thing was to do an FCM analysis. So this was the old tube. This is an old case actually when we had started doing flow cytometry. So here there's a population, okay? Again, very dim CD45, very low CD45 and a low size scatter, okay? And this was negative for dead CD19. The CD10 is also not expressed. So B cell is out, no 19, no 10, and no 20. Okay. So all B markers negative, but it expressed CD23. So this was a lymphoid tube I had put initially. You can see here the kappa and lambda are also dead because when we put a B tube, we also establish clonality, right? So kappa and lambda both are dead negative. So 19, 10, 20 negative, kappa, lambda dead negative, right? 117 is also negative here. 56 is heterogeneous. Can you see this? 56 is expressed by the blasts or the atypical cells. And CD38 is also expressed. Okay. So here's a population expressing CD38 and CD56. It is negative for all B markers. Clonality we cannot establish because it is not expressing either kappa or lambda. So yes, this was the next tube because we were thinking of hairy cell. There was some hairy cell projection. CD25, CD123 are markers we use for hairy cell. So CD25 and CD23 were both negative. Again, CD56 you can see is positive here. CD4 was also negative and CD3 was also negative. So the T markers are negative. And this is the cytoplasmic tube. Again, very dim or low CD45, cytoplasmic MPO79 alpha and CD3 all negative. So all lineage markers negative. And so this was the result, 70% gated population, negative for BT myeloid markers, negative for immaturity markers, negative for cytoplasmic markers, and only positive markers we got were CD23, CD56, and CD38 heterogeneous. So CD56, any papers of CD56, what is the possibility? NK. Okay, so what is against NK here? Can you think of an NK cell because CD56 is positive here? If you know NK cells, you know, they have a very bright CD45. They will have CD45 as bright as T cells or even brighter. Okay. So NK cells cannot lie here, right? So this is a population which is almost CD45 negative. So what is then the differential diagnosis of a CD45 negative population? So all blasts will not always be CD45. The most common example we know is a B cell ALL, right? Which is CD45 negative. Rarely AML, then some other metastatic. If you're dealing with a small round cell tumor, they may be CD45 negative. Debris, obviously, plasma cells can also be CD45 negative. And erythroid cells, M6, M7, they all can be CD45 negative. So this is the, and then nucleated RBC. So you should know that what can come in the CD45 negative population. That's my last case, don't worry. Okay. So this is the bone marrow biopsy of the case. Again, you can see that same cells replacing the whole bone marrow, right? So all marrow replaced, lot of atypical cells, again showing you prominent nuclei, vesicular nuclei. No doubt that yes, the whole marrow is replaced. This is a leukemia, and because we had an marrow, we did a IHC panel, at least the basic IHC panel. So we did LCA. We also did pan-CK. We wanted to see the small round cell mein fit ho jaye. So we did a pan-CK negative 117 MPO34 kappa lambda, all negative. Now, what to do next? When you can't make the diagnosis, you go back to the clinician and ask for help, right? So we did asked him for a further workup. Chest X-ray showed a lytic lesion at the T4 vertebra, right? There was a lytic lesion in the T4 vertebra. That can be a mess. That can be anything. Ultrasound abdomen, CCD, I wanted to do because she's a 46-year-old female. We checked the adnexa, कुछ adnexa में वो कहीं से ovary से कुछ arise कर रहा है. Nothing there. Tumor markers भी कराए, no help. Serum LDH was raised. There was raised serum calcium. Hypercalcemia, X-ray में lytic lesion. And if you remember renal failure, CRAB symptom. Okay, so CRAB symptoms are it. Next, what to do? Urine for Bence-Jones protein, basic test, negative. Serum protein electrophoresis. This is the serum protein electrophoresis. This is the positive control. A band in the gamma, monoclonal band here. This is your patient. Is there a gamma band? There is no gamma band. Okay, कोई gamma band नहीं है. Urine for Bence-Jones protein negative. अब क्या करें? Still, plasma cells had to be ruled out. और अभी इसमें क्या नहीं लगाया हमने? 38 was there, but 38 is positive in what all cells? Plasma cells के अलावा 38 can be expressed by many other cells, including some precursors. We said, So we had to put 138, right? 138 is a more useful marker. So we put the next tube which had 138. And lo and behold, we are saved. 138 is positive. So this is a population which is expressing 38 and 138. But look at the morphology. Does it really look like plasma cells? I'll go back to the morphology and show you again. Look at this. Do they look like plasma cells? They don't. And they are, this is the peripheral blood. Here you are getting so many plasma cells and then you get 38 and 138 positive. Yes, you are dealing with a plasma cell leukemia. But we put a cytoplasmic kappa and lambda also. Both were negative. Okay, so the final diagnosis was a primary plasma cell leukemia, non-producer. Okay, so this is a very, very rare entity, even they can be myeloma, 3% can be non-secretor. Non-secretors का मतलब there would be no protein in the plasma, but they have protein in the cytoplasm, immunoglobulins, right? But this was a non-producer, a primary PCL non-producing. So primary PCL as such is a rare diagnosis. Current definition has been changed. Initially, we used to need 20% plasma cells to call it as PCL. But now the definition, the International Myeloma Working Group, it has changed the PCL to 5% only, the requirement, right? What is the difference between primary and secondary plasma cell leukemia? Secondary occur after multiple myeloma. But primary PCLs, they occur in concurrence with the disease. These patients will also have multiple myeloma, but they present together, right? That's primary PCL. And definitely it is an aggressive disease as compared to multiple myeloma. The salient differences are that PCLs usually occur a decade or two younger as compared to multiple myeloma. This disease is a very aggressive disease, has a very high tumor burden. A lot of extramedullary disease, the LDH, beta-2 microglobulin, serum calcium, everything will be very high. And we know that abnormal plasma cells, they are positive for CD56. Yes? Normal plasma cells are not positive for CD56, but abnormal plasma cells in multiple myeloma express CD56. But PCLs, they lose CD56. Okay? And the reason they lose CD56, this leads to their dissemination. Because the multiple myeloma is it's not a disseminated disease. Plasma cell leukemia is a disseminated disease, and that is because of loss of CD56. But our case was CD56 positive. That was another abnormality in that case, right? So it was CD56 positive, and 10% of PCLs can be non-secretors, but non-producers are very rare. So that was the third case I wanted to show you. And that is all. Thank you so much. And I just want to summarize and say that yes, all of us are getting good cases here and there. The important thing is that we should have a systematic approach. And many of us are in institutions where we don't have access to everything at once, right? So it's important to take help, ask your colleagues, and have a systematic approach, and keep following the case and not lose the track. And that is how we can help most of the patients out. Thank you so much.